Okay, so I'll begin. Welcome everybody. You've seen. Hopefully, you can hear us. If you can't hear us, just a reminder to please turn on your audio from your computer. That's how you're going to get. That's how you're going to be able to hear the webinar today. I just want to thank you so much for joining us. My name is Sarah Lecton. I'm the Senior Vice President of Philanthropy at UJA, and I oversee the annual campaign at UJA. Thank you to so many community members who have joined us here, and thank you to so many of you who have been just extraordinarily helpful in helping, bring the community together in this very, very challenging time. As many of you know, UJA is the organization in the community that's really looking always to address the biggest challenges facing our community today. Today we have a lot of challenges. So where we normally are, looking at things like Jewish identity, anti-Semitism, advocacy, connecting people to Israel, Jewish education, and working through our more than 100 partner agencies to make sure that we're addressing various challenges in our community in those specific areas. At the moment, we are all consumed with making sure that all those things continue and that the health of our Jewish community, both individually and collectively as a community,
all the visuals, all the people,
continue. Can I just ask you to put on mute? But at the moment, we've also been very actively trying to mobilize the community to help with this current challenge of COVID-19. Just in the last week alone, we've brought forward some very large-scale community initiatives trying to reach out and make sure that we've galvanized the community in this time of crisis. We started by working closely with the National Council of Jewish Women to help them execute and really take over the execution of their Passover food drive this year. We had tents. Some of you will have seen big tents erected in the Lipa Green parking lot where we had hundreds of volunteers coming, but only in small groups at a time, spaced out, where we packed boxes for almost 2,000 families who are in need of food and who are isolated at the moment and don't have access. We've also been partnering with Vea Havta. We've given some food through RENA as well, because we've been collecting food from community members. Our UJA Genesis team has been out actively looking for community members to purchase groceries through Instacart and things like that for, again, isolated seniors and families who can't go out to the stores. We are still looking for people to help that way and lend their time. If you are willing to volunteer, don't hesitate to send us an email. And the last thing we're doing, and you may have received a call from us, is we want to make sure, as it's our responsibility to look after the health of the overall community and that we come together in these times, that every member of our community gets a phone call to check in. We have volunteers from UJA calling every member of this community to check in, see how you're doing, see if you need anything or if you know anybody who needs something, and try to either connect those people in need with a member of our social service agencies, or frankly, thank you to so many of you who have actively participated in these different volunteer initiatives over the last week. We also have a fund running for COVID-19 relief that many of you have seen and participated in that will go to addressing immediate needs of the families who are at home. So thank you for that. We wanted to bring people today to give you access to some of the leading experts in this field. I want to first welcome our speakers and, just say at the beginning that we're so pleased to host this webinar, and we hope that you're able to gain really incredible insights in this time of uncertainty from the speakers who have joined us today, and to hear about various aspects of the pandemic and really to get a sense of their unique areas of expertise. We have joining us today, Randy Wax is our moderator. I don't know if they can see you, Randy, if you can wave first. Randy's not just our moderator, but he's an incredible expert in his own right. And, I'm encouraging Randy also to give us insights during the call as you moderate, please. Then we have Dr. Gary Mann. Gary, if you can wave quickly. There you go. Gary is the program chief in the Department of Emergency Medicine at Lake Ridge Health Ajax and Pickering campus, where he is also a full-time emergency physician, and he has been for more than 38 years. So he's really on the front lines. And I think he's also done significant work with the LINs. So Gary will be able to, Dr. Mann will be able to give you significant insight into that space. Dr. Barry Pecos, who is a public health physician, program director of the Public Health and Preventative Medicine Residency Program at the Dalla Lana School of Public Health, and Global Health Lead for Postgraduate Medical Education at University of Toronto. Dr. Arthur Slutsky. Arthur, I don't know if your picture's there, if you can come, oh, there you're the big there in the middle, who's Vice President of Research at St. Mike's Hospital and Professor of Medicine, Surgery, and Biomedical Engineering at the University of Toronto. He focuses on lung failure, respiratory illness, and therapies for COVID-19. And last but not least, our moderator, Dr. Randy Wax, who's an associate professor in the Department of Critical Care at Queen's Medicine at Queen's, and also a critical care physician at Lakeridge Health. So we have a phenomenal panel. I will turn it over to you, Dr. Wax, and thank you all again for joining us on behalf of UJA. Don't hesitate to reach out if we can be of help to you, and if you think that there's a way that we can help to bring the community together in this challenging time. Thank you, and Dr. Wax, over to you.
That's great. Thanks, Sarah. So we've got a fantastic panel. I think we'll be able to address a lot of the questions and issues that people are forwarding. There were many hundreds of questions that were actually sent in before this webinar, and we try to collate them and put them together in different themes, and so that we'll be able to work with our different panelists and try to address them to the right people. But certainly everybody can feel free to chime in. What I thought we'd actually do, if we can, is start with Dr. Pecos with a number of very important and common questions that people have just about COVID-19 in general, and maybe starting with a little bit of background for people. Gary, do you mind just talking a little bit about the common symptoms that patients are having? I think you're on mute. There we go.
How about now?
Perfect. Go ahead.
Perfect. Okay. So, as folks have been hearing in the news, it is a respiratory virus. It's a virus like, in many ways, like a common cold. That the typical symptoms are fevers, headache, runny nose, cough, shortness of breath. Some of the more, unique things about it are that it can present very differently in different people. Some, as I'm sure you've heard, are totally asymptomatic. They have no symptoms at all, and others are very, very, very ill. And as I'm sure you've heard, there are certain people who are more likely to become ill with it. Certainly, older people, people with other conditions. Interestingly, men are almost twice as likely to become very, very ill or die. In most countries, it varies a little bit by country. That's one of the interesting things about it. But there are cases where you have fever and nothing but diarrhea, or there are cases where people have nothing but anosmia, which is where they can't smell different smells. So there's all those little sort of nuances at the edges, but this is really a mild to severe cold. That's what we're really looking at here.
Right, and I don't know if you want to comment on some of the challenges given the varying presentations that people have, the different symptoms for trying to diagnose this.
So one of the biggest challenges here, certainly at this stage of the pandemic, is that a lot of people who have these symptoms have a regular, regular cold, or at least certainly maybe in the weeks past, it was more likely that they had a regular old cold, and now it's actually changing very quickly to it's very likely that it be COVID. In fact, as of today or yesterday, more than half of the cases that we're seeing in Ontario are community transmission, so they're not travel related. They're cases in the community where we don't know exactly what people have got the disease from. The only way to know whether you have it, specifically COVID, is through testing right now. And as I'm sure we'll discuss, there are some challenges with testing right now that are very quickly being worked out. I think it's really important that everybody understands that this is a virus that was unknown to humanity 3 months ago. And within weeks, we had tests for it. We've got studies on it. We've had most countries around the world being quite good about releasing their data. And there are pretty good papers being published on a daily basis that each one of them add insight to what we know about this disease.
That's great. And, so the majority of people who do end up with this coronavirus getting infected and have COVID-19, the disease, the majority are hopefully going to have mild illness, but there's certainly a subset that actually can get very ill. And I just wondered if you could talk a little bit about, what proportion of people tend to get that sick and what that sort of picture looks like.
Sure. So the picture is changing all the time, but from the data we have from other countries that are more severely affected, and I'm going to give pretty big ranges here because because we don't know everything, but it is much more likely that older people or people with other conditions get ill, and around somewhere between 2 to 4%. Fatality rate around 10% get very seriously ill. Most of the cases have been, people 70 or 80 years older, up to, in the 80-year-old range, almost 25 to 30% get pretty severely ill. The good news is that with support, most of these people who become ill, at least early on in the pandemic, and needed ventilator support, a lot of them are getting better. And actually, right now, just in the past day or two, I've been in touch with a number of people in the Toronto community who have parents or loved ones in New York or New Jersey who are actually on ventilators right now, and some of them are quite young. So I think the media, for the most part, is doing a very good job at sharing some of these pertinent details with the public, and they're really being very responsible about it. So I think, whether it's the Toronto Public Health website or Public Health Ontario or Toronto Star, Globe and Mail, CBC, I think there's good information out there.
Right. And so certainly, I'm looking forward to when this is all over and to be a lot more social and see people. But certainly right now, I'm hoping not to see anybody in the hospital, because, as you know, I'm a critical care physician, so I'm one of the doctors looking after people who end up on ventilators. And I know that during normal times, certainly we're able to manage the day-to-day numbers of patients that come in requiring ventilators. And what you hear from different places in the world, like Italy, or certainly even some places in the United States, is that many hospitals are under considerable amount of stress because the number of patients all presenting at the same time requiring intensive care support and ventilators. And so you're hearing a lot about this whole concept of flattening the curve, or distributing the numbers so that even if the same number of people get infected with coronavirus, if we're able to spread it out over a much longer period, we're not going to have so many patients trying to use the limited number of ventilators and intensive care unit beds at the same time. Just wondered if you maybe walk people through a little bit this whole concept of flattening the curve and why we're doing all of this social distancing and all these dramatic things that are happening and recommendations from the government.
Right. So flattening the curve, I'm sure many people have heard of. It's this idea of spreading out, like you've said, spreading out the number of infections over time. We're trying to use the language of physical distancing. We want people to stay socially connected as much as possible, but we want them to keep apart from each other. The rough numbers are really, this will give people a bit of a sense, are that our numbers are doubling, the infected numbers and the deaths potentially, doubling every several days, every 3 to 4 days in most countries. So we're still very much at the early end of things, and it really is very different in different countries. We're going a little bit slower here, which is great news. But what as you said, what it means is spreading out the number of illnesses over time so that our healthcare system can cope and our public health system can cope. Those systems are really quite separate. And what that does mean is that the physical distancing measures that we're using are going to be lasting for a lot longer than is going to be comfortable for any of us. And just to reassure everybody that I just got off an emergency operations center call just a few minutes ago, and every different region, every health region and public health unit are working together to find extra ventilator capacity, whether that means through ordering more ventilators, whether that means through finding other spaces in the community that can be used in urgent circumstances. So there's a lot of planning that has gone on over the past years since SARS and even beforehand. We have pretty robust emergency planning infrastructure in Ontario, and we're putting it to good use now. It's not perfect, but it's pretty good.
Oh, that's great. And so one more question, people are asking a lot of questions about, why can't I go out, and go to restaurants and stay in, and why can't I go to the grocery store, or why are we sort of limiting things as much as possible? And people have been very receptive to that. And I think people are starting to get the message and how important it is to really stay at home and really only essential reasons for leaving the house. And, as we're looking at the numbers every day, the hope is that the numbers don't accelerate quickly. And so far, we think that the job that the public is doing is they're doing a very good job in trying to help us with that. Just from a timing perspective, you know, if they're seeing over the next few days, they're saying, wow, we're doing all of these things, it's really disruptive to our lives, but the numbers don't seem to be going up. Maybe I should start going out again. I don't know if you wanted to comment a little bit on, you know, what kind of timelines you look at for this to see whether or not, you know, what we're doing is making a sustained difference, or do we still need to wait a little bit to make sure that, you know, things are under control?
Yeah. So that's really important for everyone to know that this is a many weeks to months sort of planet-wide project. And I am certain the numbers are going to go up. They're going to go up quite significantly and potentially steeply, despite what we're doing. And if we weren't being as good with all of these physical distancing measures, they would be going up much faster. What's really difficult for people to understand, and whether it's individuals or people in government or really everyone, is that, you know, people understand it or are thinking about it as, you know, is it safe for me to go out? Is it safe for others because of me? But from the population level, which is, as a public health physician, how I look at things, you know, if you can go to the grocery store, you may be thinking then, and there's 10, 15 people there, why can't you also go to somewhere else where there's only 10, 15 people? In the Jewish community, certainly the big issue has been around minyan. If I can go to a grocery store with 10 people, why can't I go to a minyan with 10 people? And the answer is it's really at the population level. It's not about each of us as individuals. It's we're trying to limit the physical contact that everybody collectively has with everybody else. And the only way to do that is to absolutely, to the greatest degree possible, limit how many times you go out of the house. And that you know, really limiting, you know, to once a day. There are some jurisdictions that have said you can go out from your house, you know, once every 3 days. You know, if you're going to go, you know, to the pool hall, it's going to be closed, but that's your choice. But probably the best idea is to go just for essential groceries, you know, once every couple of days, if that, or one person from your household. So it's a long-term project, and it really is a collective, really planet-wide project.
That's great. Thank you for those are great insights. I'm going to move on to Dr. Gary Mann for a second, if that's okay. Gary, can you hear me?
Yeah, I'm good, Randy.
Great. Gary, so I wonder if you could talk a little bit about what's happening in the emergency departments and in the community. Because, you know, we generally, people, when they start getting sick or have symptoms from whatever it is, you know, they'll either see their family doctor. Sometimes people will go to the emergency department for different things. And certainly right now, there is a sense that things are different. I just wondered if you wouldn't mind talking a little bit about, you know, what are the emergency departments looking like? And, you know, if people are having symptoms of anything, whether it's something they're worried about maybe having COVID-19 or even just some other medical issue, you know, and they're having trouble figuring out where to go. I was wondering if you can walk people through a little bit about, you know, where and who to contact, and when is it appropriate to go to an emergency department, and what to do if they think they're worried that they have COVID-19.
Sure. So currently, acute care hospitals are ramping up for the potential surges that you just heard about, surges in number of sick patients. We've already established a ward in each of our hospitals that would be dedicated to patients that are ill and have tested positive. We're also planning for additional surge space if that demand happens. In the emergency department, all of our physicians and nursing staff, as well as our paramedical people, and allied health, they're assessing patients wearing appropriate personal protective equipment. We abbreviate this PPE. Depending on the patient's symptoms and conditions, there are different levels of PPE that we use. For the most part, we use the lowest, safest levels of PPE that are indicated. One major concern that we have is the rapidly depleting amounts of PPE throughout the province and the country. And this is becoming actually a global problem. And we are practicing proper goods conservation practices to preserve our PPE availability. And currently, we're in a period of decreased emergency volumes like I haven't seen in about 15 years. But the people we are seeing are much more acutely ill, for the most part. As the number of positive cases are identified, we expect volumes are going to increase significantly, while we expect the acuity to rise even more, not get lower. At our hospital corporation, we have 4 emergency departments, and we have opened a COVID assessment clinic at our largest site, with a second clinic opening tomorrow at my site, which is Ajax. We expect to be screening hundreds of patients each day going forward.
That's great, Gary. So just to kind of recap for everybody, so let's say you're worried that maybe you've got COVID-19 and you're having some symptoms, and you want to, what should you do and where should you go?
Well, if you are just concerned about the possibility that you may be positive for COVID-19, but you're not having any significant symptoms, or you're having mild symptoms such as a runny nose, a cough, a bit of a sore throat, but you're not in respiratory distress, you don't have asthma, you don't have chronic obstructive lung disease, and you don't have any other significant comorbidities, your best bet would be to call public health and to ask them if you should be attending a COVID assessment clinic. You can also call the COVID assessment clinics directly, or at least go online. And if you feel that you need to be assessed, or if it's recommended that you be assessed, you can actually fill out an application online, and you will be contacted by one of the COVID assessment physicians, of which many of my emergency physician colleagues, and including myself, have volunteered to do this when we're not on shift in the emergency department. What will happen is that you'll get a phone call from one of the physicians that is doing the COVID assessment, and based on the interview over the phone, you will either be given instructions to remain socially isolated at home and self-isolation and monitoring your symptoms, or you may be asked to come to a COVID assessment clinic for a physical in-person assessment, which may or may not include testing for COVID-19. And if you are having any symptoms at all that you are really worried about, such as shortness of breath, high fever, severe cough, or you have some of the comorbidities that I mentioned, such as COPD, diabetes, hypertension, coronary artery disease, then you should not hesitate to come to the emergency department as you would in non-COVID-19 times to be assessed.
Thanks, Gary. And so something a little bit of a different topic, but I think many of the people logged in will be interested in. I know you've spent quite a bit of time over the years connecting up with hospitals in Israel and about disaster preparedness and the things they've been doing there. Any comments or insights in what you're hearing of lessons from Israel?
Well, it's funny you should mention that, because I'm getting regular updates from my colleagues in the Ministry of Health and some of my emergency medicine colleagues in Israel, and also from Tel Aviv University, from the Department of Emergency and Disaster Preparedness. So Israel has been very tough, I would say, but in a good way, on their population in terms of increasing social isolation and social practices that keep people in their homes, keep them away from other people, but they're doing it in such a way that the population is being well looked after. And I think we'll see Israel have, I guess, proportionately less severe infection rate and less severe mortality than other parts of the world.
Well, and that brings up an interesting point, and maybe I'll go back to Barry just for 1 second. So one of the questions that popped up was this question about why we're seeing such different experiences in some parts of the world in terms of, for example, the proportion of cases that are severe or critically ill, or even the mortality rates in different areas of the world. I don't know if you wanted to comment on why it is that we're seeing such differences.
This is a really interesting and difficult question. Certainly some of the questions people have sent in were, Taiwan did this, why don't we do this? South Korea did this, and why don't we do the same? It's a pretty difficult answer. It's difficult to answer in a forum like this. There are certainly, one thing is there are different demographics in every population. Certainly there's no question. We know that Northern Italy, many countries in Europe generally have older populations than we do, but that is certainly not all of the answer. There's the robustness of the health system, and we can maybe talk about Ontario's health system in a moment, and Israel is another good example. It's not only about the health system, it's about the governance structure of the healthcare system and the public health system, which, it's boring stuff to talk about. We like to talk about how many ventilators we have, how many emergency doctors we have. But once you're in this business for a while, you realize it's actually the nitpicky details of the legislation and the governance structure that actually determine, things that are really important to people. Like, for example, one of the things people are concerned with in Ontario is, how many different messages they're getting from many different, whether it's public health authorities or hospitals or others, and that's all about governance. So one of the answers is governance globally as well. In the final analysis, I think there's two big things that determine this. There's authoritarianism and competence. And some countries all vary in terms of how authoritarian they are, whether it's China, South Korea, Canada, elsewhere, and the degree of competence as well. And the countries that are pretty authoritarian and are pretty competent, like Singapore and Taiwan and some others, are going to have a good outcome, and other countries that might not have as good an outcome. And we're where are we in Canada? We're mid-range on both of those potentially, but that's the framework I use to look at it.
That's great. And I don't know if you want to comment about sort of the numerator denominator issue about testing and how that relates to sort of severity of illness rates and mortality as well.
Right, and others may want to comment as well, but certainly some countries are doing a lot more testing, so they know, how many are in the denominator, how many people are ill, and therefore when they have deaths, it looks like a smaller proportion of the people who are sick. In Canada or in Ontario right now, we're doing a lot less testing. We're certainly ramping up, doubling in the next 2 weeks, certainly if not tripling. But one of the best metrics is actually deaths. So if you look around the world at deaths rather than cases, I think certainly in the Canadian context, you'll have a much more accurate picture of things.
Great, thank you. I'm going to move on to Dr. Slutsky. So we've worked together a long time, and I know there's two areas related to this where I think your input would be really helpful. The first one is related to research into treatments and vaccine COVID-19. I wanted to comment on what's happening out there in the world, Arthur.
Sure. Thanks, Randy. I want to make a few general comments first and maybe get into a couple of specific examples. The first one is that medical researchers and scientists have essentially dropped whatever else they're working on and focusing now on COVID-19. And they're doing that for a few reasons. One is clearly such an important problem. There's no question about that. The other is that institutions like hospitals, universities are closing down labs. And the only labs that they're allowing to do work on is people who are working on COVID-19, which is great news. I guess the third point is in terms of funding, there's increased funding for research. The Canadian government, for example, is going to put in $250 million. They've already flowed out $50 million. The process that they used was actually very efficient. Usually we think of the governments as being very slow. They've been very fast. There's a call for proposals. Research goes in a week later. You get the money 2 weeks later. I mean, it's been great. And as part of that as well, the universities, donors, people are putting in a lot of money to help to get this research off the ground, which I think is really important. The second piece I want to sort of emphasize to everybody is there's spectacular collaboration among researchers. Like business, research and science can be pretty competitive sport, but now everybody's working together. Everybody realizes how important it is. They're sending, as soon as somebody gets data, they send it out the next day. If you look at on the clinical side, we're all getting emails from colleagues in Italy and China. Here's the 30 patients I treated. Here's what worked. Here's what didn't. Like, people are just, scientists are coming together in a fantastic way. The third, I guess, general comment I want to make is sort of a word of caution. There's lots of unproven therapies that are being suggested and being used, and you see it all the time. And there's antivirals that are used for other things. There's drugs that are used for HIV. And sometimes it's tempting for physicians or for the lay public to say, well, there's no other therapy, let's try it. I think actually that's probably a mistake outside the confines of a clinical trial, because you don't really learn anything. When you give, as you know, when you give an unproven drug to a single patient, the patient could get better, could get worse. You don't really learn anything because you don't know if it's related to the drug or the natural history of the disease process. So it's really important that we use clinical trials to try and discover, what really works and what doesn't. In a clinical trial, just to educate a tiny bit, I mean, the idea here is you're comparing a drug or a device to the standard of care or a placebo. And the key issues are you randomize. So right now, if you do a trial, for example, and the physician gives drug A, they may give it to the sickest patients, and then it looks like it doesn't work, or they may give it to the less sick patients. So you have to randomize. You have to, half the patients have to get one, have to get the other, and it has to be done randomly. Ideally, this should be done blinded, so there's no biases, but that's kind of difficult to do in the context of, the kind of COVID-19 or pandemics. And the third is you need large sample sizes, ideally. And I guess, a good example is chloroquine. I mean, that's the one that sort of, everybody's talking about. The data in support of its use is pathetic, to be quite frank. It looks like it may work in the petri dish. It affects the virus, which is great. So that's there's some rationale for its use. But it's got a lot of side effects. It's got side effects. It's been used for lots of things. It's got side effects and used in thousands, millions of people are going to die because of the side effects. But if you look at the data to support it, there's one trial in 20 patients who were given the drug. It looks like the virus decreased more in the patients who got the drug, but they didn't follow all the patients. 3 of the patients weren't followed up, and one of those patients died a few days later. Might have been due to the drug. And I just saw a study that came out today, or maybe 12 hours ago, in 30 patients, absolutely no difference between patients given this and not given it. So unless you study it, unless you do it in a formal way, we're going to be, we go around in circles. It's critical that we do research, that to test clinical trials and do it effectively.
And just a comment on that as well, one thing I still can't understand with all of this is the whole toilet paper thing. And, people stockpiling toilet paper, and hydroxychloroquine may be in the same category of that. You hear people trying to stockpile this medication that not only may not be helpful, but may end up even being harmful in some cases. The data you just don't know. Certainly, I've seen a number of very sick patients who seem to be developing some heart complications related to the COVID-19, and you worry about heart rhythm problems and other side effects of these medications. So I think your point about the need to actually study this is really important.
I got to say one thing. Yeah. I'm not going to do a study randomizing patients to toilet paper, no toilet paper, just to be clear.
Thank you. And I wondered if you'd comment for a second about Canada, and in particular Canada's role in leading rapid research initiatives and collaborations as well.
Yeah, thank you. Canada, I think there's a lot of really great research going on. As I mentioned, the CIHR has funded 50 groups across Canada. If you go online, you can look at the kinds of things that are being done. It ranges from psychological support to basic mechanisms of how the virus works to clinical trials, everything. So let me highlight maybe just 2 or 3 that I think some are pretty cool. There's a company that was started by Cameron Kahn, from St. Michael's Hospital, called Blue Dot. And what Blue Dot does is it looks at how the diseases travel, how they spread. So the company has every single flight in the world, sort of 3 billion flights. They actually troll the internet in 100 different languages to find out at the basic level what's being said, what are people searching for, and then using that information. So this company, Blue Dot, had a warning about COVID-19 that came out December 31st, about 9 days before the World Health Organization knew it. And actually yesterday, Trudeau actually said that they signed a public announcement that they signed an agreement with Blue Dot. So that's research that's going on here that's leading edge. Blue Dot works with World Health Organization, the CDC, governments around the world. So that's on trying to decide where it is, how it's spread, and try to prevent that spread. There was an interesting study out of Quebec that I just read about yesterday that's randomizing lots of patients in the community to chloroquine, to colchicine or placebo. Really cool study design where it can be done in the community. People phone in, they get randomized, and then they're going to collect the data. So that we should know. I mean, that would be really interesting if that. Here's a good example of a simple drug that's currently used, and you will be able to have an answer hopefully within a month or 6 weeks about whether it's effective, because it's being done in thousands of patients with a control group. We're personally working on something called ACE2, angiotensin converting enzyme 2. This is thought to be a really important receptor. The virus enters the body. It's got these spikes on it, and the way it gets into cells is via this receptor, the ACE2 receptor. And it was discovered, the importance of this was discovered with Joseph Penninger. We did some experiments about 15 years ago in relation to SARS. And the virus then gets into the cells. It takes over the machinery of the cells. It expands. That's what injures the cells. And the lung cells have a lot of ACE2. So the cells that produce something called surfactant are affected. Well, turns out that there's a drug that was developed with Joseph Penninger in Europe that was giving ACE2. So you can actually give the drug. The idea here being if you give the drug, the virus will bind to the drug instead of to the cells, it won't get into the cells. And that could, and we're actually starting a clinical trial. We tried to do that in China, but by the time we got up and going, there were no patients there. So we're actually starting a trial probably next week based with Canadian investigators, but it's going to be done in Denmark, Austria, Germany. So it's a good example of something that's, again, multinational. People are working together. Companies, the regulatory authorities are very are approving things, and being very efficient about it. And hopefully, there in a couple of months, we'll have an answer on whether this particular drug might be helpful. So I've got some other examples, but I think I've spent enough already.
That's great. Well, I'll ask you about one other specific thing. So I have to say, I never appreciated the importance of 3D printing technology in a pandemic and response, and it's been very interesting to see the technology and the response from industry and other folks who are involved in innovations related to some of that technology. I just wondered if you had any examples or comments about that, because that's been something I hadn't been expecting, but that's actually been very helpful.
Yeah, there's actually a very interesting challenge, if you like. We've talked about ventilators, and ventilators obviously used for patients with respiratory failure, clearly very important. But we may run out, and they've run out in Italy, so that may happen. So there's something that's actually was started at McGill. It's called the Ventilator Challenge, and that's how can you design a ventilator that can easily be used, potentially 3D printed, and then spread widely. And this is really taken off. There's a tremendous interest in how to build new ventilators. The companies in the States are doing this. Ford is combined with I think 3M and GE to try and rapidly develop ventilators, and that's happening. There's a company in Toronto, a small company, that uses it's a little valve that sort of looks like for scuba diving, and it's only a few $100, and that may be something that could be used to ventilate patients. So there's tremendous interest, a lot actually happening in Canada. In fact, I would say in Toronto, mechanical ventilation, I would say the expertise in the world, we have most of the experts in the world in mechanical ventilation, absolutely no question about that. And they're doing trials as well to look at what's the best way to use the ventilator, as well as how do you increase the number of ventilators, if you like.
Perhaps you could talk a little bit about where we're at in the critical care world, specifically what is our capacity and how quickly we will get that capacity reached, and what our fallback measures will be.
Right. Thanks, Gary. That's a great question. So for those who aren't aware, the recommendation for hospitals in Ontario has been to stop elective surgeries. So only doing things that are very sort of time sensitive or emergency surgeries. And that's something that has happened in most or all hospitals just in the past week. And part of the reason for that has been to make sure that we've got critical care bed capacity, so that as sick patients are coming in with COVID-19, instead of having our intensive care unit beds and ventilators being used for those elective things that can hopefully wait a little bit, we want to make sure that we're ready in case our numbers surge up. The other thing that the hospitals have been doing is been looking very carefully at the space in the hospitals and really trying to be creative to find safe places to be able to provide ventilation and critical care support to a larger number of patients. And so, it's important to realize that, there's multiple factors that go into our ability to look after patients. We need to have a space to put them. We need to have equipment like ventilators to support them. And probably the most important resource is the staff. And so we're very fortunate in the Greater Toronto area, Ontario, Canada. Canada is one of the, I think, great centers for critical care in the world. And we've got a lot of physicians, nurses, respiratory therapists, and other staff who've got great expertise. And so we're going to be able to leverage that. And we're going to have everybody's help. It's all hands on deck if needed as the numbers go up for patients to be able to look after them. But we're also working with many other healthcare providers to teach them the basics of critical care if needed, so that they can help us critical care doctors, nurses, respiratory therapists to manage these patients. I think the other thing people don't necessarily realize that we talk a lot about ventilators in critical care and the very, very sick. We talk about a lot of people who have got mild illness at home, but there's a bunch of people in the middle that may require admission to hospital for things like oxygen or other basic sort of supports. And we're trying to also make sure there's enough capacity to look after those people as well. And so I can say that it's a challenge, certainly, to imagine looking after 150% of your usual numbers or 200% of the usual numbers. But we've challenged all the hospitals to be creative and think about, we hope that we don't need to use that capacity, but we want to be prepared so that if the numbers do rise, that we're able to help as many people as we can to look after the patients that might arrive. Thanks, Gary. Though that was a great question. Barry, I'm just going to go back to you for a second. There are a couple questions that were coming up about some real practical things, like what do we do? We've got SADRs coming up, and what's this going to look like in a couple weeks, a couple months, and what can we expect, and what recommendations should we be providing to people to be prepared for?
Sure. So Pesach is certainly something on everyone's mind. It is a time when we get together, not quite as big groups as Purim, which was a bit of a disaster in some places and not as much of a disaster in others. But just to make sure people are aware that in Toronto, in certain parts of the community, we have quite a bit of focused protection in certain parts of the community that was related to thousands and thousands of yeshiva students and others coming back into Toronto and coinciding with Purim. So Pesach is another big challenge, and I think it's just really important not to expose the most vulnerable people. And at everybody's Seder, there's going to be, or hopefully be, some older folks, your grandparents and bobis and zadis that would want to be there, and it likely won't be safe for them to be at the Seder table with the rest of the family. There are a number of alternatives that, whether it means doing a Pesach Seder a little bit earlier, or making sure everybody prepares in advance and gives the older, more vulnerable members of the family some materials to go over, making sure everybody at least has some kind of connection to the Pesach Seder. But it is going to look different. Some rabbis in Israel have suggested allowing using Zoom, despite the fact that would be a problem, certainly for religious Jews. I don't think that's going to be taken up really in the Toronto community, it seems, but that's one alternative there. But I think everybody's going to have to do their own sort of very difficult thinking about this. If there's very severe situations where there's severe depression or severe isolation, that might justify figuring out a way to do this in a creative way. But for the most part, people need to be physically distancing themselves, and having Seder, unfortunately, only with your immediate family is probably how most people are going to celebrate this year.
Randy, can I jump in for a sec?
Go ahead.
I think that the important point is that there's more and more evidence now that disease may be spread even when you're asymptomatic, and that's really the problem. So we think, oh, everybody's healthy, let's get these people together and be fine. Well, that's not fine. That's the problem. If we knew exactly who has the disease and who doesn't, it wouldn't be a problem to get people together, but we don't. So that's why we have to use this physical distancing, because we just can't define who has it and who may be spreading it.
Absolutely, and that's what's been, I think, tricky about this particular virus is that period of time where people are asymptomatic or minimally symptomatic, or you just feel, oh, I'm not 100%, but everything's okay. and you don't want to worry about it. So people may be in a little bit of denial, and certainly we see some cases like that where people are sort of waiting and waiting and waiting. And what this disease can do is it may stay mild or it may get worse later, but it's that period at the beginning when you're the highest risk, because you're really not too worried about yourself. But as you said, you're going out and you're saying, it's okay, I can meet somebody for coffee, or I can visit the Booby and the Zadie and say hi, or have them come to see me. But that is a significant risk for sure. With all the time that folks have helping some of the folks that may not be as tech savvy to be prepared to link in by video, for SATers might be a worthwhile thing to do as well. And just even in general, just to be able to connect up. I think the worries about social isolation, it's very stressful for people. We're, by nature, we're social creatures, and we're having to rely on a lot of technology. I know, for example, with kids in school having to connect up by video and the lessons that way. I mean, that's been an important thing to do, but even dance classes or other things, people are getting very creative and using the technology to keep everybody connected. So I think we have to think out of the box and try to find ways to get through this together, but we definitely don't want to hurt each other. So your comments are very important.
Randy, the other issue that we have to be very alert and be concerned about is people who have been socially isolated or socially distanced for some time, feeling well and suddenly becoming complacent and deciding that, well, maybe it's time. We've been isolated for more than the 14 days, up to 21 or 30 days, and everybody's fine. So we feel it's okay to go out. I think it needs to be stressed that until the health authorities have stated that it's okay, which we're still a long way away from, I think, that it is not okay to do that.
I saw some questions popping up. People were asking about, if I do go out, physical distance between people and washing my hands all the time. And, it's important to emphasize those are definitely important concepts, but those are the bare minimum things that you need to do if you have to go out only for essential reasons. We don't want to use those strategies as excuses to go out when we don't need to, and you're still having contact with people. So I think really important for people to recognize that. We're getting a little bit towards the end of this. There's lots of questions popping up about things like food delivery and getting access to other sort of essential services. I don't know, Barry, if you wanted to comment on that a little bit about sort of public health recommendations on how we, if people need to get access to food or medications or other things, any other sort of pieces of advice you can give people.
Sure. These are questions we get asked a lot, certainly. If someone delivers food, do you have to wipe it down? How do you treat that sort of, any surface you might have in public? And the answer still is hand washing is the best thing. So if you're going to be, picking up food from outside, you can probably pick it up, bring it in. If you feel the need to wipe it down, you can certainly do that. But after you've done that, you wash your hands for 20 seconds or more. The washing the hands for 20 seconds or more is what, or hand sanitizer, alcohol-based hand sanitizers are what destroys the virus. I mean, it's important to recognize still from an overall public health perspective that the way this is primarily transmitted is person to person. And it is very important that people be concerned about the surfaces they're touching, because droplets, can unknowingly spread, and you never know what's on surfaces. But the primary mode of transmission is person to person. So wiping down things is maybe a way to approach it, but the hand washing is the most important thing you can do. For those that have backyards, it doesn't mean you can't go outside. It means you stay on your own sort of property and don't interact with others. So if you have a backyard, you can do that. If you have a balcony, you get some fresh air. You do your best to keep healthy and exercise indoors in your own space if you can. But it is going to be difficult for everyone, certainly.
Barry, one other question came up about immunity to this, and do we have any idea about if you do get infected, what does that mean? Are you at risk of reinfection, or do we have any idea about the nature of this longer term?
So as far as we know right now, there's no reason really to believe that this coronavirus is that different in that respect from others, and our body does develop immunity to viruses that we encounter when we encounter them for the most part, and it's likely that you can't get this twice. We do not know that for certain, and there's going to be anecdotal evidence of people having it twice, or certainly testing positive for it twice. What the relationship is between people being sick and testing positive is up for debate. I think it is important. So the answer to that is that it's reasonable to think that once you've had it once, you can't have it twice, but we can't take that to the bank yet. I think it is important to talk a bit about what people are doing or potentially thinking of doing to boost immunity, and this is something that is very relevant at all times. If you look at if you Google immunity booster, there's everything under the sun that is there. There's nothing magical that you are going to find that is posted on the internet that everybody else, that the medical community isn't aware of either. So I think it's important, whether it's with respect to miracle cures or to this idea of boosting immunity generally, a well-balanced diet, of colorful foods, generally meaning fruits and vegetables, and making sure you've got some physical activity, those non-physical social interactions. Those are the best ways to make sure that your immune system is, where it should be, as good as it can be to fight this epidemic as an individual and collectively.
Randy, I want to follow up on something Barry said, which I think is important. We've got this virus spreading, but the other thing that's spreading is disinformation. And we all get emails that have all sorts of things in it that are not true, and then we spread that it gets sent to other people. So I think it's really important we go to talk to people, tell people to use reliable sources. Go online, look at everything with a bit of a twisted eye, in a sense. If you're getting something, I mean, the governments, universities, healthcare institutions have reliable sources of information. Snopes, S-N-O-P-E-S, you can go to that website. But just, passing around these emails that have disinformation is very harmful, I think, to the community, to everyone.
Yeah, I agree. It's been different. I recall, dealing with our SARS situation in Toronto, for example, many years ago. And this experience has been very different. The pace of information sharing has been unbelievable. I can't possibly keep up with all the emails, but particularly like Twitter and other social media sources. It's a bit overwhelming, actually, for many people. I agree with you 100%. You got to be careful, because there's a lot of maybe well-meaning disinformation that's out there, and maybe even some that there's certainly some people that look to take advantage of the situation. So you want to be careful about your sources, for sure. We're coming close to the end of the session. What I wanted to do is maybe take a minute, and we'll just give each of the panelists a chance to say any final words or messages that they'd like to get out to the community. Maybe, Gary, why don't we start with you first, if that's okay?
Sure, that's fine. So I know one question that I've been asked a lot by friends, relatives, colleagues outside of medicine is, are the emergency departments functioning normally during the pandemic? And the short answer to that is yes, they are functioning normally, but people really should, even more so than in normal times, think twice about going to the emergency department, because there are people who are going there who are actually sick. And the emergency department is not generally a place that we recommend to substitute for your family doctor or for going to a clinic. Although we understand that at this time, family doctors are even more difficult to get into than usual, and clinics are not operating. So I think if you have what you consider an emergency, a true emergency, then we are the place to come to. But if it's something that you don't feel is absolutely necessary to be seen, please think twice before you come to the emergency department and risk any exposure.
That's great advice, Gary, and it has been very interesting to see the rapid development of some telemedicine options. I know the government's been very supportive of trying to build that up to look for alternatives, either to going to the emergency department or if people have difficulty accessing their family doctor. So, people should stay tuned because a lot of physicians, outpatient offices are looking for different ways to support people short of having to physically come into the office or go to the emergency department. So lots of developments there as well. Barry, do you mind if I hand it over to you? Any last words or comments? Oh, you're on mute, Barry.
Sorry. There is so much to say, but I think I want to end with just some thanks to the community. I think this is a time when, while we are doing social distancing, I've certainly never been called as much or been part of as many groups trying to deal with this together as a Jewish community. There's a task force. There's all kinds of folks looking after vulnerable people, and liaising with rabbis about mikvahs and minyans and all kinds of things. Our schools have been amazing. I have 5 children, all in Jewish schools, and literally the first Monday at school, while they're at home, they had all of their lessons planned online. So I'm just very thankful about how our community has really come together, individuals and as institutions. And we just have to be, continue to be thankful. And I think and dealing with the uncertainty. A lot of people have asked, how is this going to end? And we don't know. So I think staying thankful and being comfortable with uncertainty are really my closing messages.
And I would just add a comment to that, the generosity of the community to support, community organizations, but particularly in healthcare or hospitals and other facilities. Those investments that have been made over the years are definitely paying off now, helping us to be able to respond to this. So that's always been appreciated and is going to continue to be appreciated for sure. Arthur, are you okay to maybe have a few more comments there before we wrap up?
Sure. I would just say, look, we're going to come out of this. It's going to be difficult. There's no question it's going to be difficult. Think about our parents or grandparents during the polio epidemic, we'll come out of it, and we're much better shape now than we were back then. Long term, it's going to be vaccines and the like that play a major role, and the research on terms of new therapies. But I really think in the short term, this physical distancing is critical, and that's what's made some other countries. I mean, China. We talked to people in Wuhan. It was horrible, and that could have spread. They really did a great job. So I think we have to do that. That keeping apart. It's hard, but it's in the short term. That's all that works. And the difficult part for us is, it doesn't matter what's happening now. I mean, what's happening now really has an impact 2 weeks from now or 3 weeks from now, and that's always hard to say. So you could say, well, we're doing okay, but we won't know if we're okay now until then. So take this physical distancing really seriously and be obsessive about it. I think that's what's going to help us in the short term. Long term, there's other things that are going to work. Short term, physical distancing is really important.
That's a great comment, and I do think we have to stay optimistic and really focus on the fact that we think our efforts can make a difference. So that's a really important message. My last comment, I think, before we hand it back to Sarah to finish up, I do want to say that whether it's public health, with Barry trying to look after folks in the community, whether it's Dr. Mann looking after those patients in the emergency department that are coming in, and certainly on my end, if people do get critically ill, we are here for you, and we have critical care and we have ventilators, and we hope you don't need us, but if you do, we're doing everything possible to make sure that we can give you the best chance for getting through this if you get severely ill. And so I have to say that the health system is really working hard to be as prepared as we can, but we hope that all the work that you're doing out in the community will make it unnecessary for us to be that prepared. We're ready if you need us. Sarah, why don't I go ahead and hand this over to you just to wrap up.
Thank you so much. I just want to thank all of our panelists. I mean, that was fascinating. And I think you really addressed so many issues that are on people's minds right now. I can't tell you the messages that we're getting that are flowing in, just saying that people are feeling like they have slightly more information now. And so we really, really appreciate it, because we know how incredibly busy you all are while you work to help the community and to, look for treatments and things like that. So thank you all. For those of you on the phone, again, we'll try. UJA is going to try and stay in constant touch with you to provide you with access to information, community experts, other programming for you or your children. But most of all, we're looking for community volunteers to lend some support. If you can make phone calls from home, if you can check in on people, if you're willing to buy someone groceries who's isolated at home and doesn't have access to food, if you're willing to make a contribution to our COVID-19 relief fund, please don't hesitate to be in touch. Our community comes together in these times. We're very lucky to live in one of the best communities in the world, because this is an issue that's obviously taking place around the world at the moment. But we're going to do our best to come through it together. So thank you all. If you're looking for more real-time information from us and you have social media, feel free to follow us either at UJA Federation or at UJA Genesis on Facebook or Instagram. And obviously you'll hear from us by email as well. So thank you so much to our panelists and to everyone for dialing in, and let's stay healthy and we'll get through this together.
Thank you.
Thanks, everybody.
Thank you very much.
Bye.
Bye-bye.